Hello everyone. Today, Divya and I will be talking to you guys about the disease cerebral palsy. Alright, so what is cerebral palsy? So to break it down, cerebral actually means of the brain, and palsy means paralysis or lack of muscle control. And so when you think of cerebral palsy, think about a disorder that affects a person's ability to maintain their balance and posture. And also, this is the term cerebral palsy is an umbrella term for many of the different disorders below it. It's actually the most common motor disability in kids, and it's a non-progressive disorder. And cerebral palsy affects about 1.5 to 4 per 1,000 live births in the U.S. So I just want to talk to you guys briefly about the pathophysiology of cerebral palsy. Classically, it was described as an interruption in oxygen supply or brain asphyxia, but that is now considered the later cause of cerebral palsy. They actually found that there might be several causes, either in antenatal, perinatal, or postnatal, that involve the origins of cerebral palsy. They describe it as a hypoxic ischemic event leading to a release of all these inflammatory mediators, triggering a exocytotoxic cascade, leading to cell death. And predominantly, it occurs in white matter of preterm infants, and then it occurs in the gray matter of the brainstem of full-term newborns. And so depending on where the cell death or ischemia occurs is where you'll see the symptoms. Cerebral palsy could actually be classified into 4 different types. I'll touch on each one briefly. First is the spastic, which makes up 70% of the patients. So patients will experience increased muscle tone, and their movements may appear stiff or awkward. As you see on the left, it affects the motor cortex of the brain. So different parts of the body can be affected. You could have quadriplegia, diplegia, or hemiplegia. The next type is dyskinetic, which makes up 10%. With here, it's characterized by slow and uncontrollable withering or jerky movements of the hands, feet, arms, or legs, and this is usually caused because of damage to the basal ganglia. Next is ataxic cerebral palsy, makes up 10% as well. This affects the balance and depth perception, so children will often have poor coordination and walk unsteadily with a wide-based gait. And here you'll see that it affects the cerebellum. And lastly, we have 10%. These patients actually don't belong to a single type and actually have a mixed type of symptoms based on the classifications above. Next, I'll be discussing the clinical features you'll see with cerebral palsy. Alright, so we'll break it down into different systems. First, I'll talk about the CNS. What we see in about a third of patients is seizures, and then what we can also see is visual and hearing impairments. Psychologically, patients have some intellectual disability, so we can see either like ADHD or depression, for examples. As far as GI, they do express gastroesophageal reflux. They also have a pooling of secretions in their oropharyngeal, and then because they don't have good motor control, they have poor head control, and that could actually worsen the reflux. As far as respiratory symptoms, they lack effective cough reflex, so you can see some chronic aspiration issues leading to pneumonia. Cardiovascular wise, because of the chronic respiratory system involvement, you can see pulmonary hypertension, right ventricular hypertrophy, even cardiac failure. And so this next slide is just a visual of some of the clinical features you'll see with cerebral palsy.
Alright, hi everyone, this is Divya. So we're going to talk about the anesthesia plan and considerations preoperatively, intraoperatively, and postoperatively. The preoperative considerations, common procedures are dental restoration, some spinal fusion due to scoliosis, any trach procedure, orthopedic procedures, EGD or Nissen fundoplication. See what their baseline verbal skills, visual and hearing abilities, and intellectual disabilities. Might be difficult to communicate with patients, and kids usually have their parents near them. It might be difficult IV access due to some contractures. For respiratory system, check to see if they have recurrent cold, cough, fever. They may have recurrent pneumonia or aspiration pneumonitis. Do a detailed airway exam. They are at risk for being a difficult airway. They could have TMJ with limited mouth opening. Looking at this picture on the left, you can see that this person is definitely at risk for difficult airway, and so getting prepared for that is important. Check to see if they have a latex allergy. Some CP patients have been reported to have latex allergy as well. Check to see if they have a history of pulmonary hypertension, right ventricular hypertrophy, cardiac failure, and see if they have an echo in file, or you may need to order an echo before doing an elective procedure. For neuro, assess to see if they have any seizures, whether it be recurrent seizures and managed well, or even a one-time episode of seizures. By looking at their medications, you can see that they're on seizures. Carbamazepine can actually cause induction of hepatic enzymes and reduces the duration of action of vecuronium. And sodium valproate can cause impairment in the platelet function, hepatotoxicity, and bone marrow suppression. So it's important to see what kind of medications you're on. And also, they may be on baclofen PO or baclofen pump for muscle spasms, and that should not be withheld abruptly. See if they have any muscle spasms, any position limitations due to abnormal articular joints, or any scoliosis. They do have poor laryngeal reflexes, so assess any GERD, acid reflux, and you may need to do some preoperative medications. They are very sensitive to opioids and have had episodes of delayed emergence, so if possible, use Neuraxis or regional, but any anesthetic can be used safely. Versed can be given, definitely tolerated. Use a smaller dose or avoid if they have extreme symptoms of hypotonia. And also, like I said before, assess their verbal skills because they may not be able to communicate their anxiety very well. They do have bulbar dysfunction. They could have hyperactive salivary glands, tongue thrusting, cranial nerve impairments, and impaired swallowing, which can increase their salivations. So maybe doing a preoperative glycopyrrolate dose can help decrease the salivations. This is a cute picture I found. It shows certain medications that they may be on, any type of equipment that they may have, baclofen pumps, feeding pumps, vagal nerve stimulators, and it shows what kind of surgeries they might be in for. A baclofen pump insertion, any EGDs, orthopedic procedures. Thought this was pretty cool. Okay, so intraoperatively, patient comes in, and you're positioning them in bed. They may be difficult positioning, difficult IV access, careful with pressure points. If you're doing a spinal or epidural, you might have some difficulty placing it because of their scoliosis. Like I said, prepare for a difficult airway with abnormal dentition, TMJ dysfunction, or just positioning difficulty. They do have severe reflux, so I would say put a low threshold for intubation. If you're in between LMA or intubating, go ahead and intubate. They might have severe reflux. Do a rapid sequence, and for pediatric patients, you might want to avoid inhalation inductions. They do have an increased sensitivity to succinylcholine. Some studies, some places suggest using it only in emergency, but I'll talk about that controversy soon. Decreased sensitivity to neuromuscular blockade, so use higher doses. And there are episodes of prolonged recovery though. Increase sensitivity to inhaled anesthetics and opioids, so use minimal doses. They have impaired thermoregulation and at risk for hypothermia. So monitor their temperature closely, put on bear huggers, especially if they're losing a lot of blood. Important to do also pulmonary chest recruitment because they have poor cough, poor secretion clearance, and so they can easily have atelectasis and recurrent chest infections. They're at risk for seizures. CP is not associated with malignant hyperthermia, and there are some drug-to-drug interactions for those with seizure disorders with CP. So they might have, like I said, cytochrome P450 induction by certain antileptics, and they might have epileptogenic effects with certain medications like etomidate and ketamine. So be careful if you're using those. Doing awake extubation or suction thoroughly, they have increased salivation, and they may have delayed emergence, especially if they're on baclofen, dantrolene, or botulinum toxin for their muscle spasms. Make sure you give a full neuromuscular reversal dose, and if you feel that they are not ready to be extubated because of this delayed emergence, keep them intubated and send them to ICU. So postoperative considerations, like I said, CP patients may have difficulty communicating, so they may be difficult communicating their pain, their anxiety. Consider any regional anesthesia, any peripheral nerve blocks for postoperative pain to avoid the use in opioids. They're very sensitive to that. If they're having muscle spasms postoperatively, diazepam IV can definitely be used. Like I said already, delayed emergence is common due to inherent cerebral damage of the effects of anti-seizure medications if they're on baclofen or anything. Postoperative pulmonary complications are very common due to aspiration, poor respiratory effort, and poor compliance, and they may be needed to be monitored in the PACU for several hours before going home. So, succinylcholine use in cerebral palsy patients, it's not a recent controversy, but I found multiple sides on whether or not succinylcholine can be used safely. So one side says that cerebral palsy is not an upper motor neuron lesion, and studies have shown that it does not cause succinylcholine-induced hyperkalemia. On the right side, this ASA abstract came out in 1984 saying that cerebral palsy is not an upper motor neuron lesion. With a study, it does not cause potassium increase, and this could be due to cerebral palsy not producing the muscle denervation. However, the other side says that some studies demonstrated the presence of extrajunctional acetylcholine receptors in up to 30% of cerebral palsy patients, which causes that exaggerated potassium reflux and hyperkalemia symptoms. So there are two sides to this controversy. However, there are more and more information coming out how succinylcholine is actually not contraindicated and can be safely used. With that saying, with the use of Sagamedex, there is no necessary need to use succinylcholine in a rapid sequence intubation. You can still use a high dose of alprazolam to rapidly induce a patient, and then, if need be, reverse with Sagamedex. But you can still use succinylcholine. There's no contraindication. Okay, so I will present a fictional case. Go ahead and listen, but also pause to kind of think about the answers to the question before you go to the next slide. So you have a 16-year-old female and 58 kilos in for a posterior spinal fusion, L1, L2 for scoliosis. She's had a dental procedure done at age 12, is symptomatic GERD twice a week, takes omeprazole every day, and has upper extremity contractures with muscle spasms and takes baclofen every day. And she has no drug allergies. So what more information would you like? What drugs and equipment would you set up in the room? And what are your top anesthetic priorities? So go ahead and pause the video. Some more information you would like is her anesthesia history. How well, any complications from her dental procedure, and also has she had any aspiration episodes? Has she ever been hospitalized for aspiration? do a detailed airway exam. We're expecting a difficult airway. See if she has TMJ, limited mouth opening. See her exercise tolerance, any symptoms of heart failure. Does she get short of breath pretty easily? See if she has any seizures in the past. And is the baclofen working well for her muscle spasms? And also, we want to know how well she can communicate with providers. The equipment you want in the room, definitely we're expecting a difficult airway. So have a glide in the room, a Mac and a Miller blade, have a bougie ready, and have drugs set up for rapid sequence intubation. Top priorities would definitely be safely securing the airway, preventing any aspiration during induction. You want to do a multimodal anesthetic because the CP patients are sensitive to opioids. Have a bear hugger on to prevent hypothermia. Do pulmonary recruitment maneuvers. This is going to be a long procedure, and she's going to be in the prone position. And also, you want to do an awake extubation at the end. So the procedure went well. They're closing your back in supine position. She had a twitch 1 out of 4 and reversed with neostigmine and glycopyrrolate, but her tidal volume is 10, breathing at respiratory rate 14, end tidal is 60, and her sats are dropping from 97 to 94. All her vital signs are stable. She has no cough or gag reflex. So what do you think is happening? What's your rationale for what's happening? What treatment would you do, and what's your rationale for your treatment? So you're thinking of a couple things happening. One is she probably has atelectasis, being in that position for a long time and having a long procedure. And also, CP patients have poor cough, poor secretion reflex clearance, and recurrent chest infections. So even at baseline, they may have some atelectasis. 2 is delayed emergence is pretty common. This patient is taking baclofen every day, and baclofen causes muscle weakness. So what would you do? Pulmonary recruitment maneuvers helps with the atelectasis. Make sure you have fully reversed your neuromuscular blockades, whether it be giving more neostigmine and glycopyrrolate for a full reversal dose or doing Ciamedex. If the patient is not adequately ventilating, the safest thing to do is just keep them intubated and send them to the ICU for monitoring. So now patient's in the PACU, and the PACU nurse calls you and says, the patient's awake and alert but having muscle spasms and periodically desats from 99 to 88% every 5 minutes on nasal cannula. So what are your thoughts and rationale for what's happening, and what would you tell the nurse to do? So go ahead and pause the video. So you would first go to the patient's bedside, and like we talked about, for muscle spasms, diazepam 5 to 10 milligrams IV really helps. So give that to decrease their muscle spasms. Check to see their neurostatus, are they really awake and alert? Are they able to communicate the way they communicated before? Check to see how many opioids they got, are they having some respiratory depression because they're very sensitive to opioids? Also, do you need to take off the nasal cannula and put on a face mask? And they, like we said, they're at increased risk for atelectasis. So incentive spirometry, deep cough and breathing can really help open up their lungs and do some pulmonary recruitment.
Next is our journal article that we decided to choose for our presentation. So the title of the article we decided to choose was Role of the Anesthesiologist in the Management of a Child with Cerebral Palsy. And we chose this article because it really highlighted everything about the disease process, from what it is to what we'll see in anesthesia. Just to briefly go over, the article starts with an introduction, talks about the classification of cerebral palsy, what clinical features you'll see, as well as the pathophysiology. And then after that, it goes into medical management as well as surgical procedures that you'll see. With the main ones, looks like dental, orthopedic, as well as anti-reflux surgery. It breaks down each type of surgery into its anesthetic implications and kind of the management you want to do with those. On one of the pages, there's actually a really nice diagram that shows the clinical manifestations, the anesthetic implications, and then with those listed, it will tell you different management strategies that you can use. And so we thought it was a really kind of a robust article that if we are having a patient with cerebral palsy, I would definitely take a look at it.